So at the outset, I would like to thank IOS and all the panelists here. So I'm presenting a case of a developmental cataract of a young patient of 21 years old. She had an anterior capsular adherence, which I'll be showing here in the video. So this is the cataract, developmental cataract. So I made the side ports and I'm stating the capsule here. Now I started making the rexes and then switched over to retroillumination. And slowly I'm pulling out rexes, folding up. So here I'm having a little bit of feeling of that the rexus is running away. So I try to fill up the viscoelastic into the anterior chamber. But here I get a rexus extension at the end of the rexus.
Can you, Gunjan, can you just go back?
Yeah.
Yeah. More. Before it happened. Little more, yeah.
What is the age of the patient?
21 years old.
Little back. Yeah. Dr. Gaurav?
You're talking about like where it ran away?
Yeah.
So, I would have probably managed differently, but maybe, you can ask what were you trying to do, like when it started running away?
Yeah.
What was your thought? Like,
So I was trying to get the AC filled and try to pull it into the center so that it doesn't run away. Also, I did not fill up the viscoelastic to that level that the AC was quite out. So that was I was trying to.
So I think two things that could have been done here. One is that you should have then, once you have a problem like this, it's no longer a great idea to continue with the cystitome. You should switch to a rexus forceps, and preferably a micro rexus forceps from the opposite side from a side port, so that you have better control. And then other thing is that if it's not really fibrosed, you can easily bring it back with the Bryan-Little's maneuver. That really works well, rather than trying to push it in. In fact, it's counterintuitive, and you can just put the Bryan-Little's maneuver, and then it always comes back. Even with pediatric cataract, it works beautifully well. So these two things, and otherwise, of course, you did everything right. But when you start thinking that it's going out of control, then it's best
now
to go
I've started doing it. Actually, sometimes when we are operating.
So, for case like this, I would begin with the micro scissors and a micro forceps, and lift, and then cut, lift, and cut, lift, and cut. Because what will happen is, in between those fibrotic areas, you'll be able to tear, but the fibrosis you will not be able to tear.
Yes,
so cut it,
right.
and then again tear, and then cut.
Yes,
so something.
right.
What was the cause of this cataract? I mean, what kind of a cataract was this?
Developmental cataract, sir.
Okay, because it looks developmental cataract. So what about the fellow eye?
I don't think those are fibrotic, no? Those are just in the cortex, isn't it?
It's in cortex.
No, but there was a little bit, when the microscope quality that I was operating in the peripheral center was not that great. So, but when I'm trying to get it here, it's not, it's little fibrotic.
It will not tear, so that means it's kind of.
Yes.
Do you by any chance have access to a LRC's platform?
Sir, actually I'm operating this cataract in a peripheral center, but we are operating under a good microscope, and now we are having a
because
good,
I mean, just as an additional point, this is a kind of a situation apart from the intumescent cataracts with the LRCs, though it doesn't create a free floating rexus, creates a nice little template, and you are able to take it out much more easily.
Yeah, please go ahead. So at this stage also, when you see Dr. Gaurav, when you see it has gone beneath the pupillary margin, I think you can still go there, check with
Yeah.
Kuglen Soak, where they extend. You can always try a quick pull once.
Yes, sir.
Recently I showed, I saw one of the case Dr. Saurabh Patwardhan showed in Moscow on same case. It had gone beneath, but they could able to retrieve it back.
Yeah.
In fact, if you use viscoat in that area, it'll push the iris away, and it might even give you visualization even without a Kuglin Zook or a wide tip manipulator.
Yes.
And then you can kind of do the Pran Little's maneuver and pull it back. I have a good video like that, so I can kind of relate to that.
So
And,
even
this
if you
is-
look at, sorry, I'm so sorry.
Yeah, yeah.
This is what actually Rishi's idea, and I completely concur with that. There seems to be a central plaque and peripheral areas of fibrosis.
Yes.
In between, there seems to be a fairly clear cortical area. Maybe if you had made the rexes a little smaller and run it
Yeah.
without going into those fibrotic patches, might have got a
Agreed,
more
sir.
complete
Agreed,
rexes.
sir. After when
The,
I just saw
the
the-
central one is a fibrotic pack in the center.
Yes,
Plaque.
ma'am. Yes, ma'am. You can actually look here at when this is.
We are not letting her
told-
complete the case. Actually, you carry on.
Yeah. Carry on, Gunjan.
Yeah.
Yeah.
So, sir, just wanted to add one point here. One was that I could go ahead with the FACO because I was just looking at Dr. Rohit Om Prakash et al.'s flap motility sign, where I can see the flap still fluttering. So I think that is what kept me pushing to start with the FACO and just keep on doing it here. And then I just did a very careful IA here.
See, another point is Gunjan, never come out like this suddenly, you know. So because that tear which is only there till equator, you may have a wraparound
Yes.
at the same time.
Yes.
Always maintain closed chamber
Yes.
till the end. Yeah.
Yes.
Started constructing Gunjan, so you should have instilled Phenocaine Plus at that point of time. Better visibility of this cortical removal.
The IOL is implanted inside the bag and checked that it's in the bag. So the IOL is suitably in the bag. Okay. Thank you.
I think this case was very nicely managed. Very nice, Gunjan.
Thank you.
Anything to add from Ben list? Thank you.